Now we are attending the IMW 2021, and the topic of transplant is spoken about quite immensely. And earlier, the role of transplant was tested in the EMN02 trial, and it has been published about a year ago in Lancet Journal. And it showed the importance of transplant in comparison to the comparator arm VMP, which unfortunately is not a valid treatment nowadays. And furthermore, what I think is important in this study was that the double transplant was more prolonging the PFS among high-risk patients compared to the single transplant arm. So I think this is an important finding, and still today, currently, among high-risk patients, we still reserve the second transplant, tandem transplant, for an upfront approach, regardless of the more intensive earlier regimens. And we have seen during the update results of the OPTIMUM trial from the UK myeloma group, even with a quadruplet plus a monoclonal antibody plus all the available agents, including the alkylating and an augmented Velcade type of approach after the stem cell transplant, and earlier integration of Bortezomib, they still need a longer treatment duration, which could be amplified with a second transplant, which was not included in the trial design. And regarding, again, back to the EMN02 trial, the induction regimen was VCD. So we can judge that VCD is not the best optimum induction regimen. And the IFM Dana-Farber joint study was using VRD as the induction regimen. And in that early versus late transplant, the PFS is longer in early transplant, that's for sure. And it's also an alternative that the patients who were assigned to the late transplant, not all of them got a second transplant. So today, the induction regimens are improving. Cardamon is becoming another drug to replace Bortezomib. And KCD has been tested in the Cardamon study, and KRD and KCD both have been tested in the FORTE study. And these two studies have both randomized patients against being transplanted versus no transplant and continuous therapy if no transplant was given. And in both of these studies, transplant has shown an improvement in response, depth of response. And although FORTE study is a little advanced and we have some PFS curves, I think by time we will be able to compare the effect of transplant better. And you may still judge that the induction regimens in these trials were devoid of monoclonal antibody, and for that we have the newer studies, but unfortunately these new studies that integrate daratumumab or isatuximab to the induction regimen, they do not test the role of transplant. And the studies which are reported from the US colleagues with DARA-KRD by Ola Landgren and his group, and also the results coming from the ISA-KRD from Kaitev ISL from the German group, they both show immensely high response rates, which we are accustomed to achieve after transplant. So in future, the study which the IFM group is planning, which is the MIDAS study, which is an MRD-driven study, and it has a longer duration. I think it's the Spanish people have inspired the use of 6 cycles of or ISA combination in the quadruplet, which then allows the patients to be randomized for transplant versus no transplant, again based on the MRD status. I agree with Marie Mateos that for patients with such as IRSS, low grade IRSS, such as 1 or 2 maybe, and who have been able to obtain a sustained MRD negativity, it could be possible to postpone autologous stem cell transplant. And for the rest of the patients, and for high risk for sure, we need to do at least 1 and possibly 2 transplants to be able to achieve the eradication of the myeloma clone and also prevent genomic instability to occur later.